My talk is going to be divided into two parts. The first part is to share with you some of the background and the results of the ISIS-3 study, because I'm sure most of you have not had an opportunity to directly hear the results. I will break after about 30 minutes so that you can ask me specific questions related to the data. But if you have questions related to implications of the trials and interpretation, let's leave it till the end, because in the second part, I bring in data from other studies to see whether the data are consistent or not. And then the second part, if you don't get through the whole thing, don't worry. A good proportion of that is in the handouts that you already have, so you can always go back and look at it. The starting point for the modern era of thrombolytic therapy came about from two points of view. First, people realized that you can open up arteries in coronary thrombosis. Although thrombolytic drugs like streptokinase has been available since 1956, their use really did not become very popular. And the second thing that actually helped was the concept that the thrombus was an important part of the pathophysiology of an acute infarct. For many, many decades, people argued whether the thrombus came first and then the infarct, or the infarct came first and then the thrombus. And it may seem surprising to you, and I don't think that was wholly nonsense even today. And at the end of my talk, I want to end by telling you that we still don't understand fully the role of thrombolysis in acute infarction. There are more unanswered questions posed today than, say, 2 years back. Well, the obvious point to start are the data. Where are the slides? Oh God, I'm trying to shoot myself in the face. Now, well, having done that before I shoot myself in the foot, let's start with the data. Comparing TPA versus placebo, like the data from Collen and Bostrata in Europe, showing that when you gave TPA, you were able to open out more occluded coronary arteries compared to placebo. This is old hat, we all knew that. Then there was the TIMI study and a parallel European study that showed that at 90 minutes, there was superiority of TPA compared to streptokinase, whether you measured recanalization, which is what is here, or patency, which is what is here. The difference is, in recanalization, you have an angiogram that shows that the artery is closed. In patency, you give the drug and you do your arteriogram after the drug is given. Now, the facile interpretation of these data are that TPA opens out many more arteries than streptokinase. But that is at one point in time. What happens 5 minutes later, we can't know from these data. Perhaps in the next 10 minutes, streptokinase catches up rapidly. So perhaps the question that has to be posed is differences in the rates of recanalization and the rates of early recanalization, rather than differences in the rates of persistent patency. Now, this can be highlighted by another study that compares our SCUBA, which is like TPA, compared to streptokinase. And this trial is called PRIMI, and in these 200 patients were randomized to each of these arms, and in this study they did serial angiograms. And you can see, yes, at 60 minutes, there was a significant difference. 50% more arteries, but 3/4 of the arteries were opened out here, compared to approximately half. By 90 minutes, that difference narrowed, and by about 24 hours, they were about the same. So the question we've got to ask ourselves regarding thrombolytic therapy is whether something like a 30-minute difference in achieving the same rates of patency, is that going to make a difference? 1. 2, are there other mechanisms other than thrombosis and thrombolysis that matter? 3, are there other effects of these drugs that may make a difference in one direction or another? So immediately the issue is much, much more complicated than simply saying one agent opens out more arteries than another one at 90 minutes. Now luckily, there were people who were willing not to extrapolate and asked oneself, let's find out what these agents actually do on ventricular function, on mortality, and on side effects. First, we have trials comparing streptokinase versus control therapy, looking at the effects of intravenous early treatment on ejection fraction. And there are about 9 or 10 trials. Can you actually see this at the back? Not very well? Yes or no? No. Is there some way we can make this larger? We can't. Okay. Well, we need a smaller room, you see. Now, anyway, then I'll read the numbers out to you so that you don't fall asleep. And then I'll ask the questions too. Anyway, you can see in some studies where treatment was started very early, there was big differences in ejection fraction, like a 10% difference. This is absolute terms, like 55 versus 45 units. And there were other studies in which treatment was started approximately 6 hours. There was a 3 to 5 unit, and some studies in which treatment was started very late, where there was still some benefit, but it was only 2 to 3 units. You get the same spread of data with the TPA studies, TPA versus control. Some studies showing you a moderate to largish benefit, and some studies actually showing you only a smallish benefit. Now, of course, if you produced streptokinase, you take the data from the best-looking streptokinase trial and compare it with the worst-looking TPA data, or if you produce TPA, you do the opposite thing. So obviously, the right thing is to have head-to-head comparisons. Now, there's a third thrombolytic agent that came into the fold, and what we really then had was not a tangle, but 3 agents competing with each other. And the third agent is ABSAC, which really is a super-duper form of streptokinase, which you can give like a bolus. The mechanism of action is essentially the same, gives you slightly better recanalization rates, but as I'll show you, it does slightly more of many other things too. And we'll come to that. But again here, you get the same distribution of differences in ejection fraction. In some studies as much as 8 unit difference, in some only 1 unit, and in some studies no difference. So looking at these indirect comparisons, there doesn't seem to be a whole lot to choose between them. Now really, the other sets of data that were available, can we focus that? Okay, thank you. Is the data on mortality. Because ultimately what really matters are more people alive after the treatment than whether there is a 1 or 2 unit change in ejection fraction or 1 or 2% difference in recanalization rates. Now, even cardiologists will agree about people being alive and dead. They may disagree about many other things. Now, these are trials of thrombolytic therapy within 6 hours and trials of thrombolytic therapy after 6 hours. Let me explain this graph to you because you're going to see this sort of format later on. People at the back, don't despair. All you need is a visual impression, not the exact numbers. What's plotted here is what's called the odds ratio. And odds ratio 1 means treatment is neither beneficial nor harmful. That's what this vertical line is. Anything to the left of it indicates an odds ratio less than 1, which means there were fewer deaths in the treated group. For instance, if 20% of patients died in one group and 10% died in the treated group, that's 20% down to 10%. It's a 50% reduction in the odds of death. This is a bit of an oversimplification, but that will do for the moment. Similarly, an odds ratio of 1.2 means there's a 20% excess in the risk of death. What's plotted here is the data from all the studies of streptokinase, and here you can get an odds ratio of 0.74, which means the data put together suggests a 26% risk reduction. And by 26, I mean 10% down to 7.5. So 2.5 divided by 10 is 25%. So that's what I mean by that. Now TPA, you get slightly better, but you can see these whiskers. These whiskers are what statisticians call confidence limits. What it means is how certain are you that the data truly is around that mean point. Basically, it means that the data could be anywhere there or anywhere there. So on the indirect comparisons, there's nothing much to choose on mortality. The other point to note is that almost all the trials of TPA, comparing it versus placebo, used plenty of heparin. And this is an issue that you've all heard about. Yes, in ISIS and GC, they didn't use the right sort of heparin. But here they did use the right sort of heparin, and there's not a whole lot to choose between these. The ABSAC studies seem to be somewhat better. There's about 10 studies, total of only 2,000 patients, but seems to suggest about an effect that's twice as good as that. Look at that mean point. That's about twice the distance away from this line compared to that. But again, the confidence limits are so wide that it's quite possible that the real truth is somewhere around there, or the real answer could be that ABSAC is better. Now, of course, if you were Beecham's and were manufacturing ABSAC, you would want to emphasize this comparison and not the rest. Now, the point I'm going to make to you throughout the talk is to look at the totality of the evidence and not to look at individual studies on their own or parts of individual studies. And you can always choose what you like, depending on your point of view. These are data on late treatment with thrombolytic therapy showing about a 17% reduction in mortality. So now we have clear data, the scene is set for the battle between the thrombolytic agents. Thrombolytic agents work, they save lives. At least 3 of them have been shown to save lives, and at least 3 of them have been approved by the FDA. And there is some data to suggest that late treatment also is beneficial. Okay, now what about direct head-to-head comparisons? That's really where we should put our money. TPA versus streptokinase or urokinase. Urokinase, as you know, has about the same characteristics of streptokinase, except for the fact that it is a naturally occurring product, and it also has a lower allergic potential. But look at the difference in these head-to-head comparisons. In all these trials, plenty of intravenous heparin was used, and it was used early. So you cannot fault the lack of difference in these trials in ejection fraction because of the regimen. And there are now 1, 2, 3, 4, there are 5 trials, and in all of them, there is absolutely no difference in ejection fraction. So lesson number 1, despite differences in a 90-minute patency, that is not being transferred into a difference in ejection fraction. So what would my defense be if I manufactured one of these drugs? My defense would be ejection fraction is not a good thing to look at. Or if I did a trial and I found no difference in mortality, my defense would be don't look at mortality. That's not the best endpoint to look at. And in fact, that has happened. What about ABSAC versus TPA? There's only one trial comparing the two. You can see there's similar patency in this trial, although there are other trials I must hasten to add in that shows the superior patency with TPA compared to ABSAC, but again, no difference in ejection fraction. So the available data on ejection fraction doesn't show any difference. Now, ISIS-3 was a trial. It's a very important trial to understand. It was a study that was conducted against 3 different backgrounds. The first background was it was conducted in communities like yours. It was not conducted solely in the ivory towers, so that whatever results were obtained are applicable to the communities from which it was generated. The second thing is it was done in 21 countries on 47,000 patients in 1,100 hospitals. So that is the real world situation. It is not what happens in the best hands, it's what happens in the average hands. And that has been one of the defenses of Genentech. This is not the way, Dr. So-and-so would use it. So the third issue was ISIS-2 had shown a clear benefit from aspirin. And we would all agree with that, and therefore aspirin was given to everybody. So the question here, so the 3 questions that was posed by ISIS-3 were as follows. First, which fibrinolytic agent, if any, is the best? And here we're talking of mortality and side effects. Which patients should be treated with fibrinolytic therapy? Because at the moment there's only consensus that people with ST elevation, perhaps young people, and those treated early should be the ones that should get it. The others, there's still an open question. So what ISIS-3 did was it asked the physicians to say, okay, if you think in a given patient, therapy is clearly indicated, give it. Then you randomize patients between 3 different active regimens. If in your mind the question is still open in a certain type of patient, then randomize between active and control, and the active can be one of three therapies. The third aspect was, what is the effect of adding heparin to an effective antiplatelet regimen and thrombolytic therapy? This is not the question of saying, if you didn't give aspirin, what would heparin add on? But if you gave an effective dose of aspirin, what would add on? Because that's a relevant clinical question. Right. Now, this is the design. Clear indication, which agent? Uncertain indication. Fibrinolytic therapy was no fibrinolytic therapy, and antithrombotic therapy. Remember, aspirin was recommended for everybody, and high-dose subcutaneous heparin, starting at 4 hours, that's the end of the TPA infusion, it was started, versus control. Now, the reason why this was chosen was several-fold. First, there were already 3 trials that showed that this regimen of subcutaneous heparin reduced thrombotic complications, reinfarction, and in one trial, reduced mortality. But all these 3 studies were done without using aspirin as background therapy. The second thing was the concern, based on uncontrolled data, that the combination of early intravenous heparin plus a thrombolytic agent would lead to greater intracranial bleeds. So and the fourth one, or the third other reason, was convenience. So these were the 3 reasons why they chose this regimen, and of course one can speculate what a different regimen might or might not do. Now, again, as the protocol planned, almost everybody got an antiplatelet agent, and it was usually aspirin in about 160 milligrams a day. Now, half the people got heparin because this was being tested, and most people who were allocated to receive a fibrinolytic agent got it. So approximately similar numbers of people in each group got the allocated treatment. And the results, as you've all seen in the newspaper and Wall Street Journal and on television, but not in scientific journals, is as follows. I get my best medical knowledge from the Washington Post, actually. It's the most up-to-date medical journal I know. Anyway, streptokinase, there were 10.5% mortality. TPA slightly lower, 10.3%, and ABSAC, 10.6%. It's no difference. You can see about 13,000 patients to each of these 3 active arms. So they're almost dead even, despite the fact that almost 40,000 people are randomized in these direct comparisons. Now, remember, in ISIS-3, the TPA that was used was Dutaplase, which is the TPA produced by Burroughs Wellcome. And that's why I'm going to show you this data as Dutaplase and Alteplase, which is the Genentech TPA that's being used. Again, therefore, no difference between streptokinase and TPA. I'm going to focus on the comparison between streptokinase and TPA because the ABSAC people seem to have, laid down and rolled over. But the TPA people obviously are still creating a smokescreen. So now Alteplase is the Genentech TPA, which was tested in the GC2 study, and here Alteplase was non-significantly worse than streptokinase. Now remember, while these trials were going on, Genentech was suing Burroughs Wellcome for patent protection because they claimed that the Burroughs Wellcome TPA was identical to the Genentech TPA. And these results would suggest that the results are also very similar. So you put these 2 trials together, now based on 45,000 or 50,000 people, you get almost identical mortality, 10% with TPA, 9.9% with streptokinase. So really there isn't much to choose about, and therefore the issue that ISIS did not test an agent that is applicable to the US situation is incorrect. The data from GC and ISIS match each other, and you've also seen the data on the ejection fraction. There's no difference at all. Now, what about stroke rates? This was initially the big surprise. Overall, there were 194 strokes in the TPA group compared to 146 in the streptokinase group, and there was also about 190 in the ABSAC group. Both these differences compared to this is significant at the 0.01 level. These differences are largely due to a 2.5-fold excess risk of intracranial bleeds with TPA compared to streptokinase, and a similar trend, which is also statistically significant, was seen with ABSAC. Now, the same thing was observed in GC. Okay, before I go on to the GC data, when you look at it, the main difference in strokes is seen on the first 2 days when you give the thrombolytic agent. Obviously, if it's related to the agent, you've got to see it in the same time frame in which the agent is working. So the data are consistent, and you can see 108 down to about 70, 86 versus 80, almost even after the first day, but it's in the first couple of days where you see the difference. So it is consistent with the with the pharmacology and the sort of pathophysiological expectations. Now here are the data that shows the stroke rate, and here vertical axis is plotted the cumulative stroke rate. Here's time in weeks, here's the streptokinase rate. The APSAC and the TPA are indistinguishable from each other. Each of them are highly significantly different from streptokinase, and as you can see, the major excess is in the first 2 days. Now the same thing for the intracranial bleeds, the cerebral rate, cerebral bleeds, you can see more with TPA and APSAC compared to streptokinase. Now, the combined data from GC2 and ISIS-3 on any strokes. So you see 1.3% with TPA was 0.9% with streptokinase in GC2, and in ISIS-3, 1.5% was 1.1%, and in both cases, the excess is 0.4%. It's almost identical. So one cannot then say, that, again, that the ISIS results, the TP and the GC results are different from each other. In fact, they're so similar that there's no way you can impugn that one TPA is different from another TPA, and overall, again, it's very, very clear. Okay, now here are some surprises. So surprise number 1 to people was that mortality was the same. Surprise number 2 was that when TPA was developed, because of its clot specificity, one would have expected less bleeding. But we didn't get that. In fact, we got more bleeding. And here is surprise number 3. Surprise number 3 is if an agent opened up more arteries, you would expect more reinfarction with that agent. I mean, that is, after all, the folklore of TPA. It's never been truly documented in a controlled study. And both in GC and in ISIS, the reverse happened. There were fewer reinfarctions with TPA compared to streptokinase. Most of us cannot understand why this is so. And it actually puts the entire field on its head. And in the end, I want to conclude that we really don't understand why these agents work, or at least we don't fully understand it. And you can see here that in TPA, there are 400 such events compared to 468 in the streptokinase group. And since APSAX really is a clone of streptokinase, the fact that, again, this is high compared to this seems to support the general comparison of streptokinase versus TPA. And you can see it's seen whether or not you give heparin, see aspirin alone and no heparin, so absolutely no heparin. Yet TPA had a lower reinfarction rate compared to streptokinase, and also in the presence of heparin. And the same results were seen in GC. It just does not fit our concepts of how this agent works, or supposed to work. Now, side effects of greater severity, these are not minor side effects, but major side effects are plotted here. There is undoubtedly more allergic side effect with streptokinase and APSAC compared to TPA. 43 versus 12 and 76 versus 12. You can see in every single respect, actually, APSAC comes out to be the biggest loser in this three-way comparison. Profound hypotension, again, lower with TPA, but still occurs with TPA. People think you don't get hypotension with TPA. That's incorrect. And you can see that. Now, major bleeds are identical, and major bleeds is defined as major bleeds requiring at least 1 unit of blood transfusion. So you can see here about 1% in the 3 groups. So we're not getting any real advantage with TPA except for a lower incidence of reinfarction. And I believe that is entirely true because we've seen it in 2 trials. And in fact, we did a meta-analysis of all the trials of TPA versus placebo. And even there was a lower incidence of reinfarction in the actively treated group compared to the placebo group. And this is something that nobody has explained. Now, what about the patency rate? This is the Genentech TPA regimen, and you can see overall there's a 72% patency rate in the 5 studies where you have the data, with confidence limits of 67 to 77%. Here are 3 studies with the TPA regimen used in ISIS-3, and you get 69%. So 72 versus 69%, they're really almost identical. So both the data on patency, on ejection fraction, side effects, and mortality suggest that the 2 TPAs are the same, and the data from the 2 trials suggest that are very consistent and show that other than a difference of reinfarction in favor of TPA, everything else is either neutral or harmful with TPA. Now, the background to interpreting these data are, first, we do know that antiplatelets halve the rates of reinfarction from ISIS-2. So we already have a very effective agent on board. The second is that there are fewer reinfarctions in the existing data with TPA compared to streptokinase. So if you felt that the heparin that was used in ISIS-3 and GC2 was inadequate, if anything, a more intensive heparin regimens got to be better for streptokinase rather than for TPA. Just doesn't stand to reason. Then, since you have already more hemorrhage with TPA, if you give a more aggressive regimen of heparin, there is no way you're going to reduce that hemorrhagic risk. It may be constant, but it's quite likely it's going to be higher. So and then looking at strokes, especially intracranial bleeds, again, it's possible that either more aggressive TPA regimens, for instance, faster infusions, higher doses, or whatever, or more aggressive heparin, is likely to increase that. In fact, there are indirect data that do suggest that at higher doses of TPA or faster infusions, you're going to get that. So that changes in the TPA regimen, while it might produce greater benefit, might also produce greater harm. So that both those parts of the equation have to be considered. Now here is the summary of the trials comparing TPA versus streptokinase. The data on patency at 90 minutes do undoubtedly suggest that TPA is superior to streptokinase in opening out arteries. There's no doubt about that. We're not arguing about that. But the data also suggests from a number of studies that at 24 hours, there is no difference. So somewhere between 90 minutes and 24 hours, the curves come together. But there is very good data, both the direct comparisons and the indirect comparisons, where plenty of heparin was used, that there's no difference in LV function between these two, at least as measured by ejection fraction. Again, mortality, both direct comparisons and indirect. And direct comparisons, I say 21,000, this was before ISIS-3, now you can add another 40,000 to that. Again, no difference. Strokes, both the direct comparisons and the indirect comparisons suggest more with TPA. And major bleeds actually suggest no difference, although the early data from GCD seem to suggest there were more with streptokinase. So what you see is a consistent pattern that's emerging. And the only thing inconsistent is that our preconceived notions of how thrombolytic agents should work is not being fulfilled. But the data are consistent. Right, now I want to go on to the second question, which I think really is the more interesting question. I mean, if we all agree that a thrombolytic agent works, then, and they're almost equally effective, I mean, I care less about which agent you use, but I care more whether or not you use it, and whether or not you use it in the right patients. I mean, the only difference between choosing between TPA and streptokinase is cost, and hell, America is a rich country and wastes a lot of money anyway. Now, if, in India I wouldn't use TPA, and I'm sure Dr. Shah wouldn't either in India, but that's a different issue. So who needs streptokinase? The main areas of uncertainty is ST elevation versus the rest. We all agree that people with ST elevation need it, so I'm not going to dwell on that, but I'm going to talk about the other ECGs. And the delay. The other issue, for instance, is the issue of age. Can you give it to all people and benefit, or are you going to produce more harm? So those are the areas I'm going to deal with. And in order to deal with it, I'm not going to focus on just one trial. I'm going to bring the world literature together. And we have 50,000 patients from all these major studies. So here is the data. Now, the denominators will change slightly because not all trials gave me the data the way I wanted it, but here are the data. This is the sum total, about a 12% mortality down to 10%. I want you to notice, the first thing I want you to notice is these curves. It's very hard for you to look, to see this on the small screen. And this pointer is on the blink. Do we have another pointer? Okay. I'm going to walk up here because I want you to notice a very important finding, which I'm going to expand on in the next few slides. This is the active group, and this is the control group. But notice what happens on the first day. There are more deaths in the active group compared to controls. Notice on the second day, the same thing happens. So only around the third or fourth day that the curves cross over and you're starting to see benefit. This difference of early death is highly significant in excess of thrombolytic therapy. And This, I think, is the biggest contribution of the trials. There is an unexplained hazard of thrombolytic therapy that we've never guessed before. Now, here are the data in greater detail. On the first day, there are 550 deaths in the treated group compared to 415 in the control group. Again, a 32% excess mortality that you could put half a dozen zeros before your one on the p-value. So this is real. It's there in almost all the trials. But nobody expected it, so nobody looked for it. This, on day one, the next day, day naught is the day when patients come in. And remember, when patients come in, it's half a day. Because people come in from time 0, early in the morning, till midnight, so the average time is half a day. So in the first 12 hours, we're getting this big excess. Then things start to go in the favorable direction, and that's when you start seeing the benefit. So in trying to understand the mechanism of action of thrombolytic therapy, it's useful to look at the early hazards separately from the late benefits. Okay, now I'm going to show you the data first by ECG, by age, and by time overall, and then by splitting out the early hazards, because there are some important messages there. First, ST elevation, we all agreed works. So what about bundle branch block, ST depression, and others? Thank you. Here is the data in the 13,000 people without ST elevation. There is no difference in mortality. If anything, the treated group has a slightly higher mortality than the untreated group. So this is at least an open question, and certainly at the moment, for most patients who don't have ST elevation or bundle branch block, and I'll come to bundle branch block in a minute, one should withhold therapy with thrombolytic agents. There is an extension of this. The extension of this is therefore that in unstable angina, it's unlikely that thrombolytic therapy is going to work. Now here are the data on bundle branch block. This is the control, this is the active. And you can see there is a big difference in favor, and the size of difference, 22% down to 17%, is similar to what you see with ST elevation. What this really means is what all cardiologists know. If you've got a good story and somebody's got bundle branch block, it's just the bundle branch block just makes the ECG hard to read. So now these are the data not to 6 hours, bundle branch block or ST elevation, because that's where we're seeing the benefit. Early, we're seeing about a 13.5% mortality down to 10.2%. We're seeing a slight excess in the early risk. Now look at 7 to 12 hours. Let me go back for a minute. You can see slight excess early, but by about 3 or 4 days, the curves start to diverge. Looking at 7 to 12 hours, it's taking nearly 10 days for the curve to start diverging, and the excess risk is greater. Look at 13 to 24 hours. Look at the excess risk is greater, and it takes nearly 2 weeks for the curves to cross over, and then you start seeing a later benefit. So what seems to be happening is that the early hazard is time dependent. Okay, now let's look at that same data, exclude deaths in the first day, and you're getting 9% down to 6%, about a 1/3 reduction. 7 to 12 hours, again, a clear benefit. 10.5% down to 7%, about the same size. And very late treatment, 10.2 was a 7.5%. So once you exclude the early hazards, the later benefit is independent of time. This is again totally contradictory to the way we thought about thrombolytic therapy just a few months ago. So yes, the net benefit is time dependent, but it depends on the combination of an early hazard, that is time dependent, and a late benefit, which is independent of time. So if we can understand the early hazards, we might be able to improve the benefits of thrombolytic therapy. So this is the risk, this is a summary of what I just told you. Now the same thing, I'm not going to do the slide by slide, but I'm going to now show the same data by age. People under 65, 65 to 74, over 75. Control group in all 3 cases. You can see how as people become older, they have much, much higher mortality. But in each of these 3 groups, the net benefit is the same. But look at the early hazards. It is somewhat greater in this group, in the oldest group compared to this group or this group, yet overall there is a benefit. In fact, the absolute benefit seems to be about the same. If you remove the early hazards, the absolute benefit is actually greatest in the elderly compared to the middle age. And I'm going to define middle age over 65. I'm sure many of you will be pleased with that. and under 65 here. So you can see that again, if we can do something about the early hazards, we might increase the value of the sorts of patients who could receive thrombolytic therapy and benefit. Late patients could be benefited, and the elderly can be benefited. And these are both certainly high-risk groups. Okay, so now compared to the paper that I gave you in your handout, this is what my revised expectations are after the new data have come in. Definitely treat people between 0 and 6 hours. 7 to 12 hours probably, especially if there's clear-cut ST elevation, bundle branch block, and the patient is high risk. 13 to 24 hours, there is a possibility of benefit, but at this stage, there is certainly a potential of a fair amount of hazard. So we need to keep our mind open. But age, on the other hand, the benefits are seen at all ages. This is the net benefit. It takes into account the excess early hazards, which is greater in the elderly. Age itself, therefore, is not a contraindication to treatment. And in fact, if we found a way to overcome the early hazards, the benefits may well be greater in the elderly. Right, this is the first part of my talk, and I'm going to pause here. I know most of this is probably new. I think the second half, is the more interesting part. And that's the bit that hasn't got into the newspapers. Yep.
Identify those factors that might come up with the early risk, for example, stroke.
It doesn't explain everything. I'll show you data on what it might be in a minute, but we'll come to that.
Is the bundle branch block new onset, or do you have any data on that?
No, because many of the people don't have a previous ECG.
I made a comment that I know I don't have any stocks with Genentech, so let me make that comment with that premise. My major problem with ICE studies is the very loose criteria for admission into the study. I understand the basis you're saying, like you folks are to treat. In 21 different countries, different doctors, different communities treat people very differently. So when you put together apples and oranges and grapefruits and watermelons, you come out with a crush that is so difficult to understand. And I know numbers can hide multitudes of sins, but still numbers can also hide some real truths and some data. So I have a major problem with ICE just on that basis. Originally, when I was at UCLA, I refused to participate in ICE merely because the entry criteria is very loose. They didn't care one EKG. They really didn't care whether the diagnosis was finally confirmed to be MI or not, whether enzymes are positive or not. And a lot of patients on clinical criteria can be initially thought to be MI, don't have MI. And some people may loosely treat them, some may not. And I think I have real concerns about jumping a whole host of numbers merely because of that. I think that the scientific value of a study is really dependent on how good the data gathering and how good the exclusion criteria are. And if you don't, numbers alone doesn't, my knowledge doesn't take away the...
Well, I'm glad you emphasized with the word my knowledge. I think there is this is the first time I've heard people being referred to as apples, oranges, melons, and crushes. So, right. I think there's a fundamental misconcept in what you said, and I say this without trying to be rude. I'm just wanting to put that very clearly up there. And this is not just with ISIS, this is with the concept of randomized trials. And it's not an issue of numbers, it's with the design of trials. Trials, the main reason we need randomized trials is because no two patients are alike. You can never get a homogeneous group. So, the only way you can get two groups to be similar is not by matching them, because we've gone through this for several decades, is by randomizing and then ending up with approximately similar types of patients. So number one, the internal comparison in any of these randomized trials, like ISIS or anything else, is internally valid. There's no problems there. The second issue is, although ISIS did tell people, look here, you as a clinician make a diagnosis of what you think is an MI and get the view. Number one, that is the real world. And we want an answer that is applicable to the real world. Each one of us as physicians makes our own diagnosis. And it's ridiculous to say that people who've gone through many years of training and fellowship and practice need to be told how to diagnose an acute MI. Sure, certain times they're going to be wrong and certain times they will be right. The third aspect is although you do have broad, ill-defined criteria, there are enough characteristics measured, for instance, ST segment elevation, duration of pain, age, and you can subdivide patients by whatever characteristics you choose to do so that you get more homogeneous groups. And that's the sort of data I showed you. And in ISIS 3, no matter which way you look at the data, and the same thing is true in GC2, ST elevation, no ST elevation, early, late, age, the results are identical. So even if you do have concerns with that aspect, that is not a confounder in the trial results or its applicability. So I don't really think that applies. And actually, more and more people in the world are beginning to realize that so-called rigid entry criteria for trials has been total nonsense for the last few decades. In fact, more and more NIH trials now, we're going away from that concept. So, it's a matter of people who have not been involved in trial design and understanding trial design, throwing stones. And, we clearly disagree. Yep.
One of the factors that's been, that ISIS 3 has been criticized is if you look at mortality rate, P2B is 5% across the board. ISIS 3 is 10% across the board. How can you get twice the mortality rate?
That's a very good question. In fact, you've got to compare the entry criteria of the two studies. TIMI-2B excluded people with age over 75 years. Remember, they had to get TPA, be alive up to a certain number of hours after getting TPA, and then be randomized. So the types of patients you're talking about are very different. I showed you from the first slide that a substantial proportion of their deaths is in the first 12 hours. Now, one of the hospitals in TIMI-2A and 2B, the William Beaumont Hospital, took all its patients that presented to hospital, and they looked at its criteria. When it took the patients who entered had TIMI-2B criteria, they had a 3 or 4% mortality. When they took the whole group, it was a 10%. So the differences between TIMI-2 and ISIS or GC is patient selection. It's not, you're just comparing, perhaps, from what Dr. Shah said, apples and oranges, if I may use that terrible word. So they're really non-comparable. Again, there are differences in whether people with previous strokes could get in, people with previous MIs. I mean, there's a whole host of differences in entry criteria. And if you start matching them, then immediately it becomes apparent they're very different sorts of patients.
You mentioned that the infarction rate was lower for TPA compared to streptokinase, and theorized that if we added heparin and venous heparin, increased the infarction rate, probably would have a greater effect on the streptokinase group.
But there's more room for improvement, let's put it that way.
Yeah, but isn't it also possible that heparin would have a differential effect on the infarction rate and in fact be more powerful in reducing the infarction rate?
It's possible, but I'll show you some data in the second half of this game where actually the reverse is what the available data seems to suggest. And I don't believe that, although that's what the data show, I'll point out why I don't believe that. Ultimately, I think it's going to have the same effect with TPA or streptokinase.
Any data on mixed protocols like TPA plus SK or TPA plus urokinase versus single fibrinolytic agent trials?
There are limited data from two sources that seems to suggest that the mixed protocol, TPA plus urokinase is the common, and then there's been TPA with streptokinase, you get a higher patency rate than with either agent alone, or you get a lower re-inclusion rate. These are very small trials, And really the Gusto trial is going to try to test it, and that will be a useful answer to